what I'm doing is trying to bring a variety of perspectives to the mental health arena. I now work in a national programme in England called Implementing Recovery Through Organisational Change, which as part of our last mental health strategy was actually designed to help organisations to think more about the recovery of people they served. And so that's what I still do at the moment in England, and mess around on the Equality and Human Rights Commission, sort of muttering mental health every now and then, and various government committees. But I suppose the place I actually always want to start when we're thinking about mental health challenges isn't really some upbeat place. I think we should never underestimate the challenge of mental health problems. Just what it means when someone tells you that there's something wrong, the sort of something that means you have to go and see a psychiatrist. I know that certainly when I was first diagnosed, the bottom just fell out of my world. I was absolutely convinced that I would lose my job, my friends, my home, and my sports car. And I'm very fond of my sports car. One psychiatrist did actually ask me at one point, how many sports cars have you bought, Rachel? One, honestly, only one. But I suppose, if you think about it, actually I've worked with thousands and thousands of people in England who have lost most of the things they value in life as a result of their diagnosis of mental health problems. And not just lost what they've got now, but lost their hopes and dreams for the future. The number of people I speak to who say, oh, I always wanted to be a hairdresser, but now I'm a mental patient. That people have given up on their futures. And I certainly talk about actually having met thousands and thousands of I used to be people. I used to have lots of friends, I used to be a student, I used to be a builder, I used to be a bank manager, and now I'm just a mental patient. And I'm very, very pleased that, Kingsley, you actually talked about the Second World War, Auschwitz. You do know that actually the practice of the death camps was developed in the 1930s for people who they called useless eaters. For people with mental health challenges, people with physical impairments, people with learning disabilities. And to our eternal shame, the rest of Europe sat by and watched it. But that was known that that was going on. And if you go to the Holocaust museums, there'll be the accounts of how much it costs to keep a useless person with mental health challenges alive. And they've got accounts of the amount of bread it costs, the amount of soup it costs. And I suppose that very much spurs me to say, I think everyone is a valuable human being in this world. But I think we do have some of those images of being rather useless. I don't know what it's like in Australia. You're probably much better than us in England. But I certainly think that very much we can't just think about mental health challenges as being a clinical problem, to be diagnosed and treated. I'm not saying treatment is unimportant, but what I am saying is that for many people, some of the bigger challenges are what it means to have a mental health problem in our society and all the things that that carries with them. I think actually mental health problems are as much a social and a personal challenge as they are a clinical challenge. And again, if I look at the British newspapers, you've actually got a number of choices in England if you have mental health problems. If you want, according to the newspapers, sorry, do any of you read the Daily Mail in England? I have a little badge saying hated by the Daily Mail. The Guardian quite liked me, but my mother loved that opening sentence of that article. I guess you have a choice. You can be a poor unfortunate who can't look after themselves and needs other people to make decisions for them. Or you can be a mad axe murderer. You know, unreliable, a bit dangerous, needs to be locked up for everybody else's good. Now we've run out of money in England, so we're broke. And we're trying to cut back on the welfare state. So there's increasing talk about how all these people with mental health problems are social security scroungers. They should just pull themselves together and start working and stop being a burden on the taxman. I guess, I don't know what your images are like, but I suspect I could find similar headlines in your papers. And I guess the whole image of mental health problems is that they're a burden. We're a burden on our families, we're a burden on our communities, we're a burden on society as a whole. And I don't know how far it is from being a burden to being a useless eater. That's just a thought, sorry, I will move away from from that. But I guess it's not just the big things, is it, that you lose when you, or risk losing when you develop mental health problems. It's also the little things. I know I used to always give people advice in the National Health Service in England. If you have mental health problems and work in the NHS, you really mustn't ever get cross or upset at work, because someone's bound to ask, is Rachel really all right? And of course, they don't believe you at all. The last time I was in hospital, we've got a gym at the hospital I get admitted to now. So I'd been to the gym, and I came back to the ward with the gym instructor, and someone on the ward said to me, where have you been, Rachel? And I said, I've been to the gym. This member of staff turned to the gym instructor and said, did she? Bit boggling. 3 weeks after that, and 3 weeks before that, I was responsible for a £47 million budget in the NHS. Now I couldn't even be trusted to say whether I'd been to the gym or not. I don't know whether anyone with lived experience here recognises those kind of, can they really be trusted? We've got to check up on them. And I suppose it's those kind of things that really do. People always talk about the big things. I think it's those little comments that really erode the soul in mental health services. And as I said, it's perfectly obvious in England that a lot of that prejudice spills out into mental health services. We have a large national campaign at the moment, an anti-stigma, anti-discrimination campaign called Time to Change. And they do some horrible research. And they found that people report experiencing more negative discrimination in mental health services than they do in housing, in employment, that actually it does appear to be a big issue there. And I suppose when you think about it, when you go into a mental health service, you become a list of deficits, dysfunctions and problems, don't you? Someone who needs to be looked after. I know one psychiatrist once asked me, do you live with your sister so she can look after you? And I said, no, actually, I live with my sister because she's a nurse and she can't afford to live in London without my salary. But there's that kind of assumption that you need looking after. Then there's all the stuff about risk and risk management, isn't there? And then there's those kind of narratives of fading life chances, aren't there? You'll never be able to stop taking the medication, get a stressful job, live on your own. All those kind of helping people to be realistic. I don't think it comes from a nasty place, but it certainly has a nasty effect. I know my second psychiatrist said to me, Rachel, she had to give me a little sit-down talk. And Rachel, I'm not sure you're going to be able to go back to being a clinical psychologist. This may well be too stressful for you. Maybe you can do an admin job, possibly part-time. Fortunately, I was non-compliant and she was wrong. But I think, how many people believe the experts? And it does not coming from a bad place, but I still see so many people who've told, you're very susceptible to stress. You're not going to be able to. And I guess in England we also have a very nice clear divide between them and us, the staff and the patients. Do you still in some of your mental health facilities have separate toilets? If you go into a ward, there's the staff toilets and the patient toilets. I once wrote an article saying, don't talk to me about respect until I'm fit to use your toilets. But of course for me it's nice and easy. Sometimes I get relegated to the patient toilets, and then I get promoted again to the staff toilets. And it's very confusing for systems, that. But I suppose with those kind of images in services, I think that does just reinforce that what's the point in life. So for me, every single person who experiences mental health challenges faces that challenge of rebuilding a meaningful, valued, contributing life. And I suppose for me that's actually about making sense of what happened. I know, often those big questions, why? Why me? What's the point? If you say that in a statutory mental health service in England, you get a biopsychosocial explanation. I actually don't think people are asking that, and I certainly wasn't. It was a much more philosophical, spiritual question. How can I be valuable if I'm a manic depressive? And I think those are the sorts of issues people look at. But then it's a whole sort of things about finding a new sense of who you are, finding a new sense of purpose in life, discovering that you can still do things. There may be all those lists of deficits and dysfunctions and problems, but there's another list of strengths and resilience. And I don't think we celebrate the courage of people with mental health challenges enough. There's a kind of notion that we're weak, isn't there? If you run a marathon with cancer in England, you'll be the front page of the newspapers. If you are a wounded ex-serviceman and you climb Everest, you're famous. I wonder where we celebrate the real courage that it's taken for people with mental health challenges to live with all the demons that they've faced. But then I think it's that process of growing beyond what's happened to you, rediscovering dreams and ambitions, actually pursuing those. Have we got any occupational therapists present? I'll be rude about psychologists next, it's all right. And for occupation, I'm not talking about goals. I'm not talking about the goal of washing the socks or managing money. I'm talking about those dreams, those aspirations that we have that give us a reason to get up in the morning. I've got no objection to goals, but I think we've got to have big dreams as well. Sort of big dreams and little steps, like we all have in life. I have to say, I think a bit what I think recovery isn't. I don't think it's the same as cure. Some people's problems will go away. Some people's problems will be ever present. And others will come back from time to time. They will recur. My psychiatrist, I do have to tell him about this. He's a great man, but each time I go into hospital, he said, maybe we've got it right this time, Rachel. Maybe you won't be back. And I do have to tell him, I know I'm going to be back, so you have to live with that, and we both have to work out a way of it not messing up my life too much. And I suppose it's something about, actually, you don't have to be perfect and normal to be part of life, to actually have a valued role in life. And let's face it, who of us are perfect and normal? I mean, there's a lot of you wearing glasses here. I'm sorry, you have to go away until your eyes are sorted out. I only have to wear mine for reading. But I suppose, how many of us are? And I think we've got this sort of awful thing, certainly in England, that we venerate perfection and beauty and young people, whereas actually most of us have bits that are wrong with us, but we're really important human beings as well as that. I suppose the other thing I think we've got to recognise is that recovery isn't some professional intervention. I get worried about England. We've started inventing recovery workers and recovery teams and recovery interventions. I think that's a bit of a takeover. I guess recovery is the journey of each person as they move beyond what's happened to them. The question we've got to ask about everything that we do in mental health services, whether in the statutory sector or in the community sector, is, am I helping that person on their journey, on the journey of where they want to get to, or am I getting in the way of that? Am I the travelling companion? Am I the border guard? So I do think we've got to actually say that this is a journey of a person. How then are we going to be supporting that? But I think we've also got to recognise that we don't rebuild our lives in a vacuum. We rebuild our lives in the context of a family, a community and a culture. And that family, community and culture actually determine what the meaning of mental health challenges is. I live in the city-state of London, where we have 326 languages spoken. I work with a myriad cultures, and actually the meaning of mental health challenges is different in all of those. I think it also determines the resources, the possibilities for us rebuilding our life. And of course, the people who are close to us also face the challenge of recovery, don't they? They face the challenge of helping us in our journey, but also for themselves. Because if your mother, your partner, your child is diagnosed with mental health problems, that changes your life. You have that challenge of getting your head around that. What's important in people's journey of recovery? Well, this is where I have to warn you about psychologists like me. Psychologists are very good at inventing stages of things. If you remember, we did it with bereavement. I think we've done it with addictions as well. I've got any psychologists in the room, you're probably better at it than me. We did it with addictions, isn't it? We start with pre-contemplative and I got lost. We've done it with recovery. And the stages, I believe, they start with moratorium and end with independence. But you don't have to worry about it, because do you know what? People don't follow the stages. Some go straight to stage 4 and stay there. Some go from 3 to 1 to 2. I think we've got to accept that everyone's journey is very individual. I spent the first part of my career closing some of the old asylums we had in England. And were any of you involved in doing that? We used to have ideas about what people had to do. We prepared people, didn't we? First of all, we taught them to manage money and cook meals. And I met one lovely man who's living about 3 streets away from me at the moment. And he put himself under his quilt cover and said, "Rachel, I'll move when you want me to, but please don't prepare me." And there was something about each of us chooses to cope with different challenges in our lives in different ways, don't we? You're all Australians. Cold swimming pools. How many of you are the dive in and swim a length or jump in? Have you got some of those? Thank you. I bet there's some more of you. How many of you are the let yourself in gently screaming the while, like me? Yeah? Got a few of those. Now what about sticking plasters? You've got a well stuck on plaster. How many of you rip it off all in one go? And how many of you take it off gently? You've just destroyed the entire personality theory, I'm afraid. Because do you know, some of you who let yourselves into swimming pools very gently ripped off the plaster. I think we choose to deal with different things in different ways. And one of the things we do have to do is honour how people want to go about that process of rebuilding their lives. But if we look at the experiences of people who have undertaken that enormous task of rebuilding their lives with a mental health challenge, there appear to be 3 things that are important, don't there? Hope. You have to believe that a decent life is possible if you're going to rebuild one. And I don't know what your services are like, but some of our statutory services aren't very hopeful places. In southwest London, I failed. Miserable failure after 24 years. Lovely big old building we had for our mental health services. Gates to get into the grounds. Beautiful grounds. And on those gates there were 3 signs. We do not tolerate violence. All violence will be prosecuted. We are not responsible for your possessions here. And no unauthorised access. Now, if you were walking up there to go for an appointment with a mental health worker, you're going up to visit your son or your daughter in a ward, what sort of images does that give you? Sort of abandon hope, all ye who enter here, I think is more or less what it's saying. So that actually, having people around you who believe in you, having people around you who can hold on to that hope when it's rather difficult to believe in yourself, are absolutely critical. But I think the next thing is about getting back in the driving seat of your life, isn't it? Taking back control over what you want to do in your life. What sort of help is useful for you? Becoming an expert in looking after yourself. And again, mental health, if you've got a mental health problem, there are an awful lot of experts around, aren't there? Of course, there's all the experts in services, but then there's all the experts, your friends, your next door neighbours. I know what you mean. If I was you, I would. And I think one of those big challenges is taking back control over your life, deciding how you want to live it, what actually helps you in that journey. But finally, I think we all need the chance to do the things that we value. We all need the chance to participate in our services, in our society. And I guess to be valued citizens. I suppose at one level I'm a rather simple soul. I think human beings need 3 things. Somewhere decent to live, someone to love, and something to do. But if you get into a mental health service, you develop all sorts of special needs, don't you? You develop a need to be assertively outreached. Or you develop a need for a day service. Or to be early intervened. I wonder if any of you have actually ever woken up with a burning need to be assertively outreached. I think we've got to sort of start humanising services. Someone coming out to help you may be a way of getting jobs, homes and friends. But actually it's the jobs, homes and friends, and maybe all the other things that we value in life that are really critical. But I suppose in terms of opportunity, in terms of citizenship, I think one of the critical things is the chance to contribute your talents to your community, to do something for somebody else. You tend to end up on the receiving end of everybody else's good works, and that's a really grim place to be. And I think one of the biggest challenges we face is how we can enable people, no matter how severe their mental health challenges, how we can enable people to use their talents to do something for somebody else. Obviously, work is one of the ways we do that. But actually we all contribute to our families, to our communities, to politics, to art. I think it's that challenge of doing something for somebody else. But we're very good at translating all that into therapy, aren't we? So certainly in England we have, you don't do art, you do art therapy. You don't do work, you do work therapy. And gardening therapy and walking therapy and assertiveness therapy. All of a sudden, we're not doing things for the value of other people. It's just us that we've got to do things of value for. So that opportunity to contribute, I think, is very important. So I guess for all of our mental health services, the real challenge is how we can create those hopeful, empowering environments where people can discover their possibilities and pursue their ambitions, where people can grow. And I don't think we've always been very good at creating those hope-filled environments in England. I'm sure you're much better at it here. We're not brilliant at it. But I think if we're going to do that, we've got to kind of change the relationship between services and the people and the families and the communities that we serve. And I suppose when I was training, I trained at the Institute of Psychiatry, those hallowed halls at the University of London. And I was taught that I was learning this body of knowledge that couldn't possibly be understood by mere mortals. So my job was to work out what was wrong with people and put it right. Now, of course, I was a psychologist. I didn't do that through nasty drugs. I did that through nice talking therapies. But the same idea was there. I was the expert. It was my job to put people right. And I think one of the great advances over the last couple of decades, certainly in England, has been we've actually recognised that there are two sets of experts. There are experts by all our professions and degrees and qualifications. And there are experts by lived experience, an expertise based on the narratives of our lives, the narratives of other lives that have been lived in a similar place to ours. And, professionals don't have all the answers. I know a great friend of mine said her recovery started when she realised the mental health services didn't know everything. And she started actually recognising her own talents. But if we're going to do that, I think creating recovery-focused services, first of all, requires that we really recognise the expertise of lived experience. I'm sure there are some people who are the relatives and friends of people with mental health challenges here. I often go and ask services, do you work with families and friends? And they say, oh yes, we provide education for families and friends. The question I ask is, do you ever allow yourself to be educated by somebody who knows that family better? It's a kind of one-way street from the experts, whereas actually we know that most support for people with mental health challenges in our communities comes from people's relatives and friends. Relatives and friends have developed a huge expertise, and you have, haven't you? You all know what to do when your nearest and dearest is upset, don't you? When they're having a real strop. Some of you will have nearest and dearest who you have to leave well alone. Others that have nearest and dearest where you have to make lots of cups of tea and say, yes dear, how awful. We all know actually a lot about what helps our nearest and dearest. That sort of expertise needs to be in our systems. And I think we've got to make that expertise of lived experience available to other people who are facing similar challenges. We need to bring together that expertise of lived experience and the expertise of professionals on equal terms, don't we? Not professionals always trump you. You have this concept of insight, don't you? If you agree with the professionals, you've got insight. If you don't, then you haven't. But of course you realise that insight is just impossible these days. In the olden days, it was simply agreeing with your doctor, wasn't it? But now you've got these psychologists and occupational therapists and nurses and social workers. They don't agree with each other. So how the hell are we supposed to have insight? I won't go there. But there is something about actually really recognising both of those and trying to bring those together in a different way. Generally, co-producing well-being, co-producing services that support well-being. So I think we've got to be absolutely clear that the expertise of lived experience is absolutely central to providing recovery-focused support and services. I'm going to talk first of all about making the expertise of lived experience available to people who are using services. I guess many people have found that the best travelling companions are people who've walked a similar path, maybe are a few steps ahead, and that applies if you've got a diagnosis yourself, or if you're the relative or friends of someone who has a diagnosis themselves. Others who have faced those similar challenges can often help you to feel less alone. I think everyone at some stage has thought, I'm the only one. I'm cut off from that world. I think it also offers you support from someone who actually understands what you're going through, someone who can relate to some of the things you're saying. It allows you to share your experiences, working out different ways of understanding things, getting tips about how to deal with challenges you face. But most of all, it offers you images of possibility. If they've done it, maybe, just maybe, I could do that too. And of course, in the area of giving, it also allows you to use challenging things that have happened in your life to help other people. And using your experience to help others is often an enormous way of actually making sense of that experience. I guess there's lots of ways of harnessing that power of peer support. I think the underrated one is collecting and sharing stories, recovery stories, stories of possibility. I don't know, women's magazines are full of them, aren't they? I don't know about men. But you know, those my battle with alcohol, or we actually gain something from reading those. Philip Pullman said that true stories are nutritious and sustaining. They feed the mind with information and the heart with hope and strength. I think there's something about that. Then, of course, there's a sort of naturally occurring peer support. In inpatient units in England, it used to happen in the smoking room. The staff didn't want to go in because they might get polluted. So people could actually support each other, or in waiting rooms. Then there are all sorts of informal arrangements to share experience. And of course, peer-run support groups, community organisations, both for relatives and for people with lived experience. Nowadays, of course, we've got e-groups. You know, my nephews, you don't have to see people in person anymore, do you? You've either got to be in text contact or put things on your Facebook. The woman I write with, I went out for dinner with her daughter at her daughter's new house just before I came here. And before we were allowed to start eating, she had to take a picture of it and put it on Facebook. I mean, I don't live my life like that. Sorry, I'm old. But I guess those e-groups, that is really important. Loads of buddying, mentoring programs, peer-led programs in mental health services. But I think increasingly, if we're going to value the expertise of lived experience and make it available to everyone, we've got to start thinking about the skill mix in our services. We need professionals, yes, but we also need, amongst our staff, to have people with that lived experience, to offer images of possibility to everyone there. And one of the things we've been doing a lot as part of the Implementing Recovery programme is helping people to create peer support worker positions across our services. I think at the last count there were around 500 peer support worker positions in statutory clinical services across England. And then, of course, loads and loads more in NGOs and community services. And I think those are workers who actually use their own experience of mental health problems and trauma to help other people to find their own way. I guess we're not actually talking about with peer support workers another set of experts. It would be very easy to have another set of experts telling you what to do. In Arizona, they talked about peer support as being an expert in not being an expert, and that takes a lot of expertise. It's very easy to tell people what to do. It's much more difficult to help them to find their own way. And I guess peer support workers do offer an awful lot of things: understanding, acceptance, images of possibility, practical information, ideas about coping, and different ways of understanding what's happened to you. I think, as with any other worker, we have to think about how you're going to use your lived experience to help someone else. It's not a question of spending hours telling your story, which you bore people to death. I guess it's really about how we actually provide that peer training to help people to become peer support workers. And we've also had to recognise that not everyone's a very good peer support worker. Some people aren't in a place at the moment where they can actually do that. But we have, if you look at the literature, had an enormous set of benefits from peer support work. Increased hope, people feeling that they're accepted more, and particularly in the British context, fewer readmissions and longer community tenure and less use of services. Sorry, we're broke, you understand, so we have to reduce the number of people using our services. Not directly, but this has actually helped us to do that. For the peer support workers themselves, it has helped them hugely in their journey. Increased self-esteem, increased confidence. And there have actually been huge benefits, as you gathered from that, for the teams themselves. That improved communication, changes in attitudes. The woman peer support worker on that ward had been compulsorily detained under the Mental Health Act on that ward 3 years previously. And actually, they're so proud of her. You know, look, and it was really astounding. I was involved in her starting there in the preparation. Just how people suddenly felt they maybe did something that was useful. I think the consultant there was right. It does actually break down those sort of destructive barriers between them and us. There are some objections. One of the objections in England was, Rachel, we won't be able to tell jokes in team meetings anymore. Now, I wasn't aware that mental health problems gave you a humorectomy. But he was saying the right thing. You have to think about how you speak, what you say about people, how we talk about people, how we think about people, if you're not sure whether the person sitting next to you is one of them or us. And I do think that actually there is something about the way we talk and think about people determines how we actually behave towards those people. And that in itself has been an enormous change. Peer support workers are one way of bringing together that expertise of lived experience, that expertise of professionals. But I think we've actually also got to think about how we do that more generally, not just in relation to individual clients, but in relation to our development of services, our delivery of services. And that is working together differently in what we've called moving from what we would call user involvement, you call consumer involvement, to a genuine co-production. And I guess it's maybe different in Australia. But when we talk about consumer involvement in England, we essentially talk about involving them in our services. So we do consultation, which means a few experts go away in a darkened room and work out the answer, and then ask people what they think about it. Now, maybe your consultations are a bit different here, but that's our usual experience of consultation in England. Then there's getting feedback. What do you think of our services? And then staff decide what to do with that feedback. And then, of course, there's the other way, where you get a room full of consumers and carers, and you say, what do you want? As if there were no restrictions on that, no economic barriers, no... And then, of course, the job is to say, yes, that's a really good idea, but... You go your butt first before... And that's something like, yes, but, is something that people get very fed up with hearing. You know, we'll have one or two consumers on a committee, makes us feel good. And we tend to see consumers as this undifferentiated mass. You get, what is the consumer view? Well, I don't know. Different one for each person, probably. But we also forget that people have other skills. They didn't actually, none of that team knew that that woman actually had a PhD in self-harm. But she was able to bring that to really good use to that team. But of course, when she was a patient, we didn't actually find that out. When we're talking about co-production, we're talking about something rather different, moving away from that consultation and tokenistic participation to really meaningful power sharing, that equal partnership, pooling different kinds of expertise, and not just thinking about how we design services, but how we use those talents in the delivery of services as well, moving away from telling them what to do to actually how are we going to change things together. And I guess it does require us to do some really quite big jumps of faith. People are sometimes experts in knowing what helps them. Now, individuals and their relatives often know what helps. People can actually play an active role in meeting their needs. It's not that passive recipients waiting to be fixed. People can actually help each other. Mutual aid and peer support must be a core part of co-production. And you know, there are communities out there, and not communities with other mental health services. There are all sorts of resources in our communities. How are we actually bringing them in to thinking about co-producing services? I also think it needs a slight redefinition of what we think about as an outcome. In Britain, outcomes tend to be measured by symptom reduction and whether we got rid of you from services. Throughput. Not coming back. No, I'm sure you don't do horrid things like that here, but our KPIs tend to be about that. Actually, there's another set of outcomes, aren't there? Those less tangible issues, what relationships were like, what it was like to use the service. Actually, did it improve my life, not just my symptoms? You know, one way of doing co-production, but I guess there are a number of principles. First of all, we recognise the people who use our service not as burdens on the system, but actually as assets, the real wealth that we've often not tapped, and we build on those strengths. I think we often forget that actually there's a whole set of skills out there. We can actually enable people to use those talents, and if we do, then we're actually helping them in their journey of recovery because they'll be contributing those talents to our services. And if people can't contribute to our services, how the hell do we expect to persuade people they can contribute outside in a wider world? I suppose it's also about that breaking down the barriers between them and us, those lovely phrases, mutuality and reciprocity. I don't know what they mean in fancy language anyway. It's something about actually moving from them and us to we. This is our problem. What are the barriers that we face? How can we get around them? And that applies both staff and service users. But also, how can we actually work together to deliver this service? Share responsibility for that. And then there's looking at a wider world. How can we actually look at peer networks, community networks, as an essential part of our services, as part of the wealth that we can draw on beyond the mental health diaspora? And then, of course, there's the issue about, do we see ourselves as delivering services, or do we see ourselves as facilitating things to happen? Enabling, being catalysts to the development of networks that we all rely on. And certainly that catalyst to development of networks is something that we've been looking at a bit. In southwest London, where I used to work, one of the biggest challenges that people faced who experienced mental health problems was loneliness. I don't know whether that applies here, but certainly in my book, loneliness, social isolation if you want to use the fancy terms, but loneliness actually traps a lot of people in services and stops them actually rebuilding their lives. And in southwest London, my ex-PA actually, who had lived experience of mental health problems, said, we're fed up with actually trying to be involved in trust services. We actually want to start finding our own solutions. And he set up this thing called Prosper, which is a community network that enables people to support each other. And he decided he was doing a number of things. Individual action, helping people to take more control over their lives, building up resilience, self-management, but a lot of collective action. Increasing actually peer-led initiatives, peer groups, and then community action. You know, how can we make sure that the swimming baths is accessible to people with mental health challenges and the college and such like. And this was actually, it takes 1.5 workers, this network, and it has about 300 people in it at the moment. And those 1.5 workers are paid for by the statutory mental health service to actually facilitate this network. So it's very much acting as a catalyst to that realm of social support. And they've done a number of things. They have a space where people can come and meet once a month. But they've also developed buddy systems for people leaving services to help them actually to set up their lives, navigators to help people to access things in the community. They've set up training for their workers, their volunteers. None of these people are paid. There's 1.5 posts that help it. And it's all about a community of people getting what they need from that community, but also giving back to that community in the form of organising things. I think co-production means, I'm sorry, that's your Richmond fan. I do apologise. I'm knocking over posters. I've got the badge on. I think it's very much that moving from token representation to equal partnership, from consulting to working together, from asking consumer opinions to actually developing services jointly, from professionals taking responsibility for providing everything to us actually designing and delivering things together, to thinking about what outcomes people themselves want from services, as well as the KPIs. I can't get rid of them, but I can add to them. And of course, moving from seeing service users, consumers as an undifferentiated mass, to actually seeing the range of talents that there are amongst our consumers and families. But it isn't easy. It requires both of us getting out of the trenches and into that no man's land. It means staff have got to actually start believing people. And it means that consumers actually have to start saying, I'm part of the solution. It's not just saying to people what they've got to do. And I do think it's also about us all moving a bit outside service land and saying there's a wealth of stuff out there. How can we actually enable people to go to the Ramblers Association or the Refugee Association or the Creative Arts thing or the football club? They're all resources there in our communities. But it does appear to be worthwhile. Certainly been a lot of research looking at the impact of co-production. Improved sense of belonging, social networks, reduced stigma, increased skills, employability, reduced need for services. I always have to put that in England because we're broke. Better physical health and well-being, and very much improved relationships within services. Services feel different and actually relate differently when we do that. And I guess the value is increasing the capacity of our services. Actually, if we bring in communities and peer networks, we've got a hell of a lot more capacity than we've got just from professionals. And that, of course, has monetary value. It saves you money. And there's calculations on that. But it also is really important for the individuals concerned, that actually contributing to the provision of a service actually helps you in your journey of recovery. And I just want to finish by this bit by talking about actually the woman. It was the woman with fair hair on the film. She talks about how in 2010, 5 years ago, the only contact she had was with services, and her diary was full up with a load of list of professionals she saw, from psychiatrists to community psychiatric nurses to lawyers to family workers to social workers. Through co-production, she's actually developed a social network that's changed dramatically. She's involved with all sorts of people in all sorts of different capacities, through peer support training, in policy meetings. She works at a recovery college they have there. And in doing that, she's actually sorted out her debt problems with a bit of help from the CAB. And most importantly for her, she's now a governor at her children's school. Whereas 2 years previously, she'd been fighting in the family courts to keep custody of her children. And her life has really been turned around by actually starting to see herself as a valuable person. And that those them and us barriers have been hugely reduced. She was really anxious about going to work somewhere where she'd once been treated. But she was just delighted to find that actually everyone thought it was wonderful, that she was actually a valued member of the team. And they've gone on film to say that now. There wasn't that sense of them and us. And many of the staff have actually said to her, I can't believe you were ever here. Again, it's those images of possibility for everyone. And I guess it's something about how you've actually become a valued human being again. So I'm going to shut up there, because I think it's really about our services. How do we genuinely use and value that expertise of lived experience? I don't know how far you've got. I know you've got some wonderful initiatives that I've seen around Australia, and of course here in ACT. But I still certainly think we've got a long way to go in England. I think we're supposed to break for coffee. I'm sorry I've gone on a bit. I do apologise. I apologise. I've deprived you of your coffee.
Can we take a break if we're going on?